now live now, and we are live
Yes.
now. Hello. So, good afternoon, all. It is a pleasure to welcome you all to this important virtual discussion organized by Voice of Healthcare to observe Epidemic Preparedness Day, themed as Epidemic Preparedness Lesson Learned and the Way Forward. The discussion aimed to foster dialogue on critical strategies and innovative approach for better epidemic preparedness and response, bringing together some of the most esteemed speaker and thought leader in the field. To start, it is a pleasure to introduce our distinguished panelist for today. We have Dr. P. Ganeshkumar, Scientist E and Head, Division of Non-Communicable Diseases, ICMR, National Institute of Epidemiology. We have Dr. Tina Rawal, Senior Research Scientist, Public Health Foundation of India. We have Dr. M. Venkatachalapalli, Honorable National Joint Secretary, Indian Medical Association. We also have Dr. Sanjib Bandyopadhyay from Central Council Member, Indian Public Health Association and Associate Professor, Department of Community Medicine, Burdwan Medical College. Now, I would like to introduce our session moderator, Dr. Shubnum Singh, Principal Advisor, Health Policy, Confederation of Indian Industry, and Board Member, Healthcare Sector Skill Council. Thank you all for taking the time to join us today. Without further ado, I would like to hand over the session to Dr. Shubnam Singh to lead the discussion. Over to you, ma'am.
Thank you. Namaskar. Good afternoon to everybody and our esteemed panelists for this very, very important session on a wet and rainy day in Delhi. Hopefully, the weather is not so bad in other parts of the country. Given the fact how a single rain can bring an entire city to a standstill, the effect of what a pandemic or an epidemic can make happen, I don't have to belabor the pain that we all went through when we were struck by COVID 19. Earlier, the episodes would come in a decade or 2 decades. Having said that, with fast urbanization and the fact that zoonotic diseases crossing over to human beings, these epidemics and pandemics, I believe, according to what we are anticipating, will happen far more often at intervals of 3 to 5 years. So I compliment Voice of Healthcare for taking up this very, very important time with such an esteemed panel to discuss it, as well as share it with everybody so that we are well aware of it. I'll restrict my comments because we have the panel here very well versed in each part. But if we all go back and look at what had happened in COVID 19 and what were the key marquee things that happened to pull us out of that horrific place, showed it showed that it's extremely, extremely important to be prepared for such epidemics and not think it's not going to happen in my lifetime. Responses to it have to be timely. Global cooperation, we couldn't have had a better way to join hands across the world. And the world did actually join hands, slowly but surely. Surprisingly, community engagement was so strong, the sense of helping each other and making sure that together everybody moves like Noah's Ark to get rid of this. The importance of communication across the world, and very, very important that there was definitely, of course, we can always find faults with it. Infrastructure was not there, so on and so forth. But there was an equitable access in most of the world. Having said that as my opening remarks, it's my pleasure now to move right into with all the experts and pose the questions which I think are top of the mind for all of us today. I'll move to Dr. Ganeshkumar first. Sir, based on your extensive work at the National Institute of Epidemiology, what crucial lessons have we learned from our recent epidemic that might help us in the future? Over to you, sir.
Thank you, Dr. Shubnum, and also I thank the initiative of Voice of Healthcare for this epidemic preparedness. I work as a scientist at the National Institute of Epidemiology. I worked continuously during a COVID-19 pandemic along with the health systems. On my observation in the field and as well as working along with the health system, with the recent the pandemic and as well as other epidemics like we can call Nipah, Zika, whichever happened recently, some of the important key takeaways which I wanted to say is that data is the key aspect of all these things. We need to have a credible data which is being established by our surveillance system, which is Integrated Disease Surveillance Program, operated through an integrated health information portal. That credible data provides us kind of an immediate insight about change in the pattern of the disease over a period of time. Continuous monitoring over that surveillance is a key important point, and that helps us for an early detection of the particular disease or a specific new disease coming up. That's why we learned a new disease called an Nipah which was re-emerged. And the same way, an unexplained pneumonia was identified through the surveillance system in Wuhan and subsequently in many parts of the country. The second important thing is that the data-driven response is a key important takeaway, which we need to always do that. We successfully established a genomic surveillance network through which we have been kept on informed by whether any new pathogens have been coming up, any new variants have been coming up, circulating among the population. So the second important thing is that though all these data and systems are there, we need a strengthened health system to get operated at the ground level. So a well-connected, strengthened health system, both at primary care, secondary and tertiary care, not just bigger hospitals. The best part of our pandemic response depends upon the primary care, which is often not being discussed in the larger domain. So a well-strengthened primary care system is a key success for facing any kind of like an identifying the early epidemics and pandemics. And we need to have an established communication platform which will bring a lot of take away the myths regarding the information. And finally, always as a health system together, health system, when I say it's collectively government, private, non-government, everyone to work together with some kind of a mechanism with involving professional societies to bring active collaborations so that whenever immediate pooling of resources is required during these times, hard times, it will be done. So these are my initial early remarks and reflections on what are the important lessons we learned from the recent pandemic. Over.
Excellent, sir. And I think you brought out a very critical part, that is the strength of the primary care system, which is like the fulcrum around which everything revolves. So with that, Tina, if I may come to you, Dr. Tina Rawal, as a researcher, how have you found that whatever research work, your past research and findings, translated the health sector into actionable strategies for the epidemic preparedness? How did they feed in?
Thank you so much, Dr. Shabnam. Yeah.
Please.
Thank you so much, Dr. Shabnam, for your question. And just to share my experience in terms of the public health, like the experiences what we had at PHFI, and the various teams have been involved in various parts of the, I think, components under the epidemic response. And some of the examples what I just wanted to highlight as a part of this webinar. So maybe the first, I think Dr. Ganesh has already been highlighted, the strengthening of the surveillance system and need for the real-time data which is there, and along with that, advancing the vaccine development. So coming from the different varied information and the experience, what we have been seeing is looking at the development of platform for accelerating the vaccine development, plus how we can just cope up with the vaccine hesitancy. So there, I think the need for the community engagement, where we can just generate and create awareness. How important is the vaccine? I think uptake at the community level. Then also at the building the public health infrastructure, that how it is important for the establishment of the isolation wards, ICU, especially if we are dealing with COVID-19, and strengthening the rural healthcare, especially under the government initiatives like Ayushman Bharat. There is a need for the enhancing the public health workforce as well, that upskilling the community health workers, especially dealing with the grassroots epidemic management, where the information, the trust can be created at the community level, and how the information can be disseminated to counter the misinformation, which is, I think, was the need what we have seen during the COVID-19, especially through social medias or the real time, I think, the information what has been generated and created. Some of the examples where we have engaged the public health experts and creating this awareness, motivating the adolescents as the change agents, how adolescents can be part of this entire journey, and creating this awareness at the community level, and leveraging the technology. So what we have seen from the government initiatives, the deployment of the Arogya Setu app and tracing the COVID-19, that was an initiative which was really impacted the real-time data for collecting the data around the vaccine. And some of the important examples where PHFI has been selected by the Ministry of Health. And this is one of the example where the team from the PHFI has been selected by the MHFW to provide technical services as an independent verification agency for transforming India's public health system for pandemic preparedness program. So these are some of the experiences and the initiatives what as a PHFI, as a team, has been contributing and contributed in the past. Thank you.
Excellent. I think the point of what you've highlighted of adolescents being a very vital part in the communication part, considering that they are digitally savvy, as Dr. Ganeshkumar also said, the dependence on data and the use of the apps is critical. So the adolescents who are digitally literate, they definitely played a very vital and critical part in making this entire piece move the way it should. So with that, I'll move to Dr. Sanjib Bandyopadhyay. Dr. In your mind, and I think Dr. Ganeshkumar also highlighted this, that the involvement of professional associations, right, is
Yes.
extremely critical. And going forward, how would it be? What would be the best way to engage with them to contribute to the preparedness perspective of epidemics? Over to you, sir.
Thank you, Dr. Shubnum, and thank you, Voice of Healthcare, for inviting me in this important panel discussion. Indian Public Health Association, since its inception in 1856, mainly focuses on promotion and advancement of public health in India, and also the promotion and protection of public and personal health of the people of the country. So not only Indian Public Health Association, other associations like Indian Medical Association, all these professional health associations, they play a crucial role in influencing public health policies, particularly in the context of epidemic preparedness. So to name a few, firstly, providing expert guidance and evidence-based recommendations, because the professionals of health associations, they consist of leading experts in their fields, in the field of medicines, field of public health, epidemiology. Their scientific and clinical expertise allows them to provide evidence-based recommendations for epidemic preparedness and response. Secondly, these health associations advocate for increased investment in public health infrastructure, research, and epidemic preparedness. And these researches include many things like uh, vaccine related research, like disease trends, their epidemiology, what should be the effective interventions, like uh, quarantine methods, everything which we have seen during COVID time. And these health associations can develop certain standards and best practices that guide the healthcare providers and public health officials on how to manage and prevent the spread of the disease during the epidemics. Uh, Example, use of personal protective equipment and the hospital protocols for managing infectious patients. Public awareness campaign through different healthcare professionals should be continued because the importance of different preventive measures in the form of vaccination, hygienic practice, social distancing through various channels, including media, schools, community outreach, is important because public health policies are more effective when the population understands the risk and is willing to comply with these preventive measures. Health associations influence policy by pushing for clear, consistent public health messaging. Another important point is multi-sectoral collaboration with different sectors like education sector, agriculture, transportation, police department to ensure a holistic response to the epidemics. Because a coordinated multi-sectoral approach leads to more comprehensive epidemic preparedness policies that address all aspects of a crisis, from the healthcare to social support and economic recovery. Many professional health organizations focus on training healthcare workers, public health professionals, and emergency responders on how to prepare and manage for the epidemics effectively. So, because well trained healthcare workers are always critical to epidemic control and policies that prioritize training and workforce development, ensure that public health system can respond swiftly and effectively. To name some other few, like monitoring and evaluating the health system, because monitoring activities can help policymakers to understand the effectiveness of their strategies and identify the gaps or the areas that needs improvement, allowing for data-driven adjustment to policies. And lastly, there must be advocacy from different health organizations for the equity in epidemic preparedness, mainly for the marginalized peoples like low income communities, racial minorities, elderly, and the people with underlying health conditions. So these are my submission as different healthcare organizations, what they can do to promote health policies.
Excellent, excellent. So, essentially, if I were to, not that I want to summarize it, but some of the key points that you brought out is that the professional bodies bring in that whole might of evidence that yes, this is what it is, this is how it is to be taken care of by way of standard treatment guidelines. And since they are the last mile connectivity between people and being on the curative side, the monitoring part to say what is working from on the basis of policy, they become that crucial link to make things happen in the ecosystem. I think that point also is very clear that on a single basis it doesn't happen, but multi-sectoral approach is extremely, extremely important. So I'll circle back with Dr. Ganeshkumar. So, Dr. Ganeshkumar, we had the entrance of the mRNA vaccine for the first time deployed at such a large scale. In the initial stages, because of the panic, people did not ask too many questions. But as time has evolved, everybody has different points of view, right or wrong, as to the whether they could trust this. On the other hand, this has also shown that you need to have something in the pipeline. If you don't have something in the pipeline and something new hits, like you rightly pointed out, two conditions, then there is nothing in your armory if you've not already been working. So, your thoughts on this as to uh, what is it that we need to do, to ensure that there is this continuous research work for these vaccinations, and how can they be rapidly deployed when and if they are needed? Over to you, sir.
Thank you for that particular question, Dr. Shubnam. Particularly, these kind of what we call as new age vaccines, which is related to this epidemic preparedness. mRNA technology provides a kind of a fantastic platform in order to easily adapt the emerging pathogens, and also it reduces the time for the pathogen identification to the vaccine deployment. It accelerates the vaccine development, the mRNA technology. As a country, we need to develop within our country in-house a lot of capacity around it, right from discovery to development and as well as to the delivery of it. When I say the discovery, we all know that the discovery of that particular mRNA vaccine linking to the respective pathogens, and development is that making it as a kind of like a vaccine which is gone through the respective trials. We need to have the scientific capacity to do that within the country, and we demonstrated during COVID-19. And the third thing is that is delivery of it. We again demonstrated through a robust platform called CoVIN and as well as other kind of platforms. Of course, there are many implementation challenges and process issues. However, we overcome that swiftly with a large capacity of scaling up the vaccination across the country. That is called the delivery part of it. So not just the discovery of the vaccines and the technology, we need to also equally need to have structures and the capacity within the country to develop it, which is passed through the trial and as well as to do the delivery of it. The second important thing is that we need to also house some kind of like global pathogen libraries, which we need to in-house have that. These kind of libraries are very helpful, which is very helpful for many biotechnology research, which act as a repository for the pathogen data, helpful to identify the antigens and develop some of the crucial antibodies for the vaccine development. In vaccine research, this helps largely into it. Third thing, over a period of time, we need to also learn simultaneously when we are developing the capacity. Second thing we need to also do is that ease of doing science mechanism, which is easing out, or I would say like streamlining the regulatory mechanisms. We know that how regulatory mechanisms work within our country. So some kind of like a regulatory flexibility, we need to keep advocating it. People like here who we are gone through the particular process, more industrial partners, more development partners can be brought in, conversed, and we need to do advocacy on the regulatory flexibility, how to streamline the regulatory pathways, how to bring some kind of like harmonized global standards, which is inculcated within the country mechanism. We need to also establish, we need to invest a lot on some of the technology platforms. For example, like in order to do some kind of like a discovery of these vaccines, or even in terms of newer drug discovery for epidemic preparedness, definitely we need to have some kind of like an omics and other drug discovery technologies. We need to have higher capacity computing capacity in order to do the drug discovery. So a lot to be invested on that particular technology also to be there. Further, as I said, that like capacity is the most important crucial role which we need to simultaneously invest when we wanted to really prepare ourselves for the next pandemic or the next epidemic. So that capacity, it full the entire life cycle of it, start from the discovery or in terms of development or in terms of delivery, and as well as it also holds a good in order to monitor all these aspects. The technology capacity, everything falls into it. Over. Thank you.
Excellent. So, as, to make sure that we are, I can't say fully prepared, but relatively well established and prepared, uh, the requirement to have global platforms right from the stage of discovery to commercialization. There has to be a harmonization and sharing of information between people, and that will require a huge amount of funding. And unless people don't commit to that funding, there will always be gaps and the ball will fall in those gaps, and then we will find ourselves exposed. So I think that is one of the most critical things that you have uh, repeatedly said, and I think that would be one of the biggest challenges, to get everybody on the same platform. And everybody will say, oh, I put in 10%, and somebody will say 20%, and somebody will say I paid 80, and therefore I take precedence. We've had this. So this would be real. It is vital to have this, and unless we start the dialogue, rather the conversation around it, resolution will be far really doomed. So, Tina, we keep coming back to building infrastructure, strengthening workforce, right? What kind of investments do you see should be coming into healthcare to fill this gap? Because without capacity, the physical infrastructure will not come in. So you won't have the requisite number of primary care or hospital bed, whether it's in tertiary or primary or secondary care. And simultaneously, if we don't have the workforce, there's nobody to deliver that care. So, your points of view on this, Tina?
I think very, very important, and what has been highlighted, that building the capacity, it's not only at the healthcare level, but I think at all the levels when we are looking at the community engagement. So there is a need to strengthen the healthcare access, especially the healthcare access in the rural and the remote area. We are just about to initiate a one program where we are looking at the healthcare access, especially in the tribal population, where I think just to which may lead to inequitable access. So those are the initiatives where we can have it to build the capacities of not only the healthcare professionals, including doctor, nurses, or the public health workers, but also at the community level, where we can also involve adolescents, the teachers who can care and take this information in a trusted way with the community levels. Also, I think it's not only a challenge which is there for the inadequate health infrastructure, where we can have an appropriate availability of the resources in terms of the healthcare infrastructure, but also creating a community engagement and awareness, which is very, very important, and create and support the healthcare systems in their own way. I think improving the number of trained public health workers, including the community healthcare professionals, strengthening the disease surveillance, what has been highlighted by I think, the earlier discussions, and at the same time building the resilient infrastructures, whatever the capacity what we have right now. I think the access and the quality, especially for the rural and underserved area, is of primary and priority, which is there in the current scenario. And also at the same point, promoting the public health literacy through various campaigns, through mass media information, and maybe how we can just increase and improve the information which is there at the community level through different mechanisms and medias. And at the last, I think encouraging the public private partnerships, which is very, very important to foster scaling the innovations and the services and improve the efficacy of the resource utilization. So those are some of the, I think, highlights which we have seen in some of our projects, and just wanted to share those with the group. Thank you.
Thank you. So I'll move now to Dr. Venkatachalapathy. So, with your role in IMA, right through the conversation, the primary care piece stands out as being the most critical component of being able to take care of anything. While to some degree at the level of tertiary care and secondary care, doctors, skilled workers are there. Given the large number of people that I has, 2 lakh plus, they are the front end soldiers for this, right? So not only are we short of doctors as well as everybody else, but there seems to be this large void in primary care. From the Medical Association, what do you think should be done and how can we strengthen this very, very vital piece with the association?
Yeah. Good afternoon, everybody. Uh, at the outset, I would like to thank the organizers, Voice of Healthcare, for bringing out such a wonderful program on this important day, that is International Day of Epidemic Preparedness 2024. In fact, I am very lucky to be part of this panel where I'm not supposed to be, but because of my Honorary General Secretary was very busy. In fact, we are all in Hyderabad at the National IMA conference. So he told me to, day before yesterday, to be participating in this important event because he was supposed to be there to conduct the official business. So in that way, I am very thankful to the organizers, and I feel very privileged to be part of this program. And to start with, yes, prevention is better than cure. And who else should take up this job? I think it is very obvious that from the what our panelists have already spoken, particularly Dr. Ganeshkumar sir, who initially only commented that it is not that we should stress more on tertiary. It is equally important that we give lot of importance to the primary health care system. And coming to the primary healthcare system, where do we stand? Primary healthcare system in the public sector and in the private sector, rather, I would see it in that way. In the public healthcare system, we have primary health centers which will cater to the prefixed population. But in the private system, nowadays we are not seeing this general practitioners or family physicians who are the first interaction for any kind of a small problem or whatever the problem it could be. They were the people pillars to the family, where we always used to look at the general practitioners. So in that way, a general practitioner or family physician concept is now eroding. So coming back to the public system, public healthcare system, or the primary health centers, in fact, whatever that the title that says that lesson learned, definitely we have learned a lot of things, and we learned that we were not at all sufficient to tackle these things at the primary healthcare center, be it the shortage of the skilled manpower, doctors, nurses, paramedical staff, equipments, medicines, and even oxygen for that matter was scarce during the second wave rather. And in fact, we don't have a proper referral system starting from the primary. We feel shortage even at there is no correct referral system. So that has to be evolved properly. So that will cut short the timing by the patient when he reaches to the higher centers. And once again, one more problem is that the person who mans the whole show, the medical officer at the PHC level, he is burdened with lot of other non-clinical works rather than the official or clerical jobs, like attending a meeting at the headquarters, and even doing a lot of statistical work. They are most likely, they're burdened most of the time, are burdened and burnt out. So not getting even a proper training in frequent intervals regarding what is expected, what are all the things that you can expect in coming days, particularly with the background of the epidemic. So those are my initial comments. So always it is better to have as we said, they said prevention is better than cure. So that is the cornerstone. So prevention should be our main aim, so that the burden on the tertiary care will be lessened, and also on the expenses, on the out of pocket expenses also would come down.
So, uh, just to stay with you, Dr. Venkatachalapathy, I've had these conversations with Dr. Sokan on the platform of TB many a time, right? And the sense that is there with the individual doctors, the private doctors, as you rightfully said, they are the ones who provide care. There seems to be a lack of involvement from the public side to bring them into the fore of providing care. So in the public system, though we talk about public private participation, the involvement of the GPs, right? And as you rightly pointed out, today a young doctor does not take family medicine as an MD, right? They always want to move into other areas. What can be
PGs, yeah.
done to bring them into the fold, the private sector, whatever limited number of GPs that we have, to become more engaged and active in primary care? What do you
No,
think?
now I think it is very difficult, because uh, family physician has no such, they every doctor wants a specialty. So they are not thinking that the family physician profession is lucrative or whatever it is. That may be one reason. So most of the graduates, they go for post graduation. Invariably they will go for post graduation. So that is very difficult thing. But as far as the primary health center, yes, in fact, the family of the doctors, they cannot go back and stay in a remote places or rural places, doctors, because they have their families to look after. They want to have their children to be well educated. So most of them will usually try to be attached somewhere in the urban areas. They will even stay in the urban areas, and may they go morning and come back in the evening, something like that. They will be doing, because unless the infrastructure for a doctor is good at the primary health center level, it is very difficult to continue to that argument. Yes, there is a lot of inequitable distribution of the manpower, skilled manpower, and that to skilled professional manpower. And let me correct you also, madam, that we are of 3.8 lakh doctors in IMA. They are registered in Indian Medical Association. And and in India, there is no dearth of doctors. In fact, there are around 12 lakh allopathic medical doctors in India. I'm talking only on behalf of 3.8 doctors who are registered under Indian Medical Association. So that is the huge numbers for a 1.4 billion population. And you have around nearly 12 lakh allopathic doctors. I'm not talking about non-allopathic doctors. They may be playing some role somewhere. So, but allopathic doctors, yes, we are around 12 lakh doctors registered in Medical Council of India, now called as NMC. So it is only the inequitable distribution of the doctors that is creating problem, rather, I feel.
That's a great point, and gives me a segue to Dr. Sanjib. Dr. Sanjib Bandyopadhyay, given the fact that you are with uh, Burdwan Medical College, and the challenge in rural healthcare systems continues. So, if I were to take it as what Dr. Saab has said, that there are 12 lakh doctors, right, registered
Yes.
with Medical Council of India. Clearly 2.8, 3.8 with the Indian Medical Association, give or take, it is about 7.5, which is the gap. Uh, and we have this great rural healthcare challenge, which directly impacts epidemics and pandemics, because they are the source of data to do predictive analysis, etc., etc. What are your thoughts on this?
And as per my personal experience during working during COVID time, Rural healthcare system faced several distinct challenges, uh, including limited access to healthcare facilities. Means rural areas often have fewer healthcare facilities, and those that exist that are usually under-resourced. Hospital and clinics may be far apart, making it difficult for patients to receive timely care. Another point, there is shortage of healthcare personnel. As already our previous panelist said about that, that most of the doctors, they are trying to reside in urban areas. So rural areas are already facing the dearth of doctors, and those who are present there, means the existing workforce, they are also lacking the specialized training. So during this pandemic or in any epidemic, uh, training, proper training for infectious disease management should be there. Otherwise, there must be problem. And what I think that there must be some incentives for retention, like financial incentives, housing allowance, or professional development opportunities, which can attract and retain healthcare workers to rural areas. I'm giving one example that during COVID time, government of West Bengal started one COVID quota for postgraduate admission. So which I think helped much. There are other problems like shortage of healthcare personnel, uh, inadequate infrastructure, like not only healthcare infrastructures in rural areas, other infrastructures like electricity, water, internet service, which are all essential during an epidemic. And very rightly pointed out by one of our previous speakers that public-private partnership can do a lot in all these sectors. And another thing, what I want to mention here, that there are some situations that some people need that much of attention which we could not give in a rural area. For that, the patient must be referred to a urban area with a high-end hospital setup. So in that case, if we think of rural area, the transport system is also very important so that the delay in communication we can mitigate. There are other problems like limited public health surveillance and data collection system in rural health areas. There might be some cultural and language barriers because rural populations may have distinct cultural practices or speak different languages, making it difficult to communicate public health messages very effectively. So there should be development of targeted public health campaigns in local languages and culturally sensitive formats. So use local influencers or community leaders to disseminate that important information may be effective in that case. There is another important areas like lack of trust in healthcare system. Because if we see our experience in COVID-19, there were always changes of guidelines, different times, that how many days one should be quarantined, how many days one should be isolated. So continuous changing of guidelines. And in that case, a transparent public health message from the higher authority should be communicated that what are the reasons for changing those guidelines. I think that is also very important. Financial resources is always limited in rural healthcare service. But apart from that, what we faced during COVID-19, that in some rural areas, there may be resistance to public health measures like quarantine, social distancing, and vaccination due to misinformation or cultural factors. Use of local media channels like radio, local newspaper, social medias to communicate public health guidelines and their importance uh, might be of some help in that case. And we can also use some mobile apps, some digital apps, mobile health units, telemedicine services to give them proper service during this epidemic or pandemic. Over to you, ma'am.
Excellent points. Excellent points. And I think that the cultural context in which you are operating, the contextualization of that is extremely important. I think there can be absolutely no uh, denying that. It's like many years ago, somebody from overseas had come to the office and he said, before we go any further in our conversation, does this mean yes and this means yes also, or does it mean no? So in our context, both mean yes. So it does have a huge effect on how we communicate. Dr. Ganeshkumar, we've gone through with everybody and we are on our last and final round. There's this constant need which has been brought out for policymakers, industry, multi stakeholder, the entire ecosystem. Where do you see ICMR? Because everybody looks up at ICMR, rightfully so, to give guidance as to how should they be collaborating so that there are truly implementable strategies on the ground. Because very often we have fantastic policies, all guidelines, but when, like they say, the dirt hits the road, in the operational world, it just goes all over the place. So, how can we strengthen this? What is it that we are missing out in the operational part of this relationship?
Yeah, thank you, Dr. Shubnam. I see ICMR plays a very pivotal role in bridging some of the gaps, not just on scientific research, but it's also on policy and as well as bringing various important key leaders to implement an evidence-based epidemic response strategies. I'll tell you some of the activities how this could happen. One, in terms of like an research, ICMR is one of the largest funding agency in this country. Currently, we have streamlined our funding in terms of three different funding. One is called an small grant, which is up to 2 crores, and 2 to 8 crores is called the intermediate grant. And we have national research priorities up to 15 to 20 crores. We have been identifying what are all the important research areas, what are all the important areas which will be required for the future. For this example, an important public health areas like prevention of the pandemic, the future, and pandemic preparedness. We've been routing a lot of funding through many other institutions, academic bodies in order to carry out the research. Some of the things which I could list is, one is discovery of new vaccines, discovery of new drugs, and another is that delivery research in order to find out what are all the better implementation strategies to disseminate a newer technology across the country. The second important part, which I strongly believe is in terms of evidence-based policy making. ICMR is a catalyst always in order to provide key important data by means of its research findings and as well as its funded researchers to the policymakers important for the decision making, especially during epidemics during recent pandemic we have demonstrated. We've been identifying what is the important pathogens and what are the important actions that will culminate all these pandemic and as well as its ill effects. We have also instrumental in coming up with the guidelines and protocols with respect to surveillance, with respect to diagnosis, treatment, based on the latest evidence whichever is available. Apart from that, ICMR as a public agency is fostering a lot of dialogues between multiple partners, which includes private, which includes industry, and as well as non-governmental and academic organizations, in order to identify what are the important areas of work. Very simple is that to identify key research areas and bring partnerships to do that. ICMR also has established a MedTech Mintra in order to do the technology transfer for important technologies which makes key role like establishing pathogen libraries, bio banks, development of newer diagnostics and vaccines, bringing industries together, and as well as converting the research into the practice on that. Apart from all these things, finally for the capacity building, ICMR is one of the other next agency apart from NCDC, which is implementing a large level field epidemiology training program. I myself is a course coordinator of India Field Epidemiology Training Program, where we are improving the skills of the government officials who are posted as program managers and epidemiologists at the district and state level, who can improve their capacity to analyze their data and epidemiologically try to bring considerations. So, with all these kind of like in pivotally, our organization has a larger role of it. But however, nothing can happen without effective collaborations. We always look upon effective collaborators like academia, private partners, public-private partnership, associations, societies, and most important are industries. Over.
Thank you. Thank you so much for Dr. Ganeshkumar. And if you hold the thoughts, when I go to Dr. Venkatachalapathy, I'll just link something there. But first to Dr. Tina Rawal, you have emphasized the role of the community. And the involvement of the community reaped great benefits to us in COVID-19. How do you think what would you think is the best way to institutionalize this engagement so that not only is the impact order, but it is in perpetuity? Because if something is institutionalized, it is there forever. Over to you, Tina.
Thank you, Dr. Shubnum. I think very, very important that the community-driven initiatives, how they can play a role in the epidemic preparedness. So this have a very, very important role by fostering trust, which we have seen, I think, in COVID-19, that how the people like maybe the community leaders have played an important role in creating awareness around vaccine uptake, improving health literacy, enhancing early detection, facilitating rapid response, especially during the health crisis, and the initiative how they can leverage the local knowledge, networks, resources to address this kind of a public health challenges in culturally relevant and context sensitive way, what we have discussed and heard, I think, from the earlier speaker. And scaling up such efforts, I think, can ensure the broader impact, particularly in diverse and resource limited settings like us, where we need, I think, to have building the capacity at all the levels. So there is a need that how the community members can be trained and they can act as a health volunteers and can be the first line of defense in identifying the unusual pattern or the illness or maybe the disease control. In example, I think how ashas and the peer leaders under the programs like RKSK, they have been instrumental in creating this awareness at the grassroots level, promoting the health literacy. For example, the community-led campaigns to counter misinformation, how to educate people about the preventive measures, symptoms, treatment options, where we have seen, I think, during COVID-19, that a lot of emphasis has been created to build the capacity at the community level so that there is information which is there, which can be disseminated at the larger space. The community workers can be disseminated accurate information about vaccine, the safety protocols, helping combating the vaccine hesitancy and enhancing the trust in healthcare interventions. I think trusted community leaders and organizations can bridge the gaps between the healthcare providers and the population, especially in the marginalized communities, what we have seen. Improving the accessibility, like they can provide the localized healthcare delivery, ensuring essential services reaching to underserved areas. We have seen many case studies and examples how people from the community helped in ensuring the availability and delivery of essential medication during the COVID-19. And some of the examples that has been quoted by the community health workers plus the peer leaders at the adolescents, how they have contributed in ensuring the delivery of this essential medications. In terms of community health workers and the networks, they can also quickly mobilize the resources such as food, shelter, medical supplies during such outbreaks. Then local advocates can encourage the behavior that reduce the dissemination, such as hand washing, social distancing, and integrating it into the school curriculum, which is very, very important, that integrating these initiatives in the school curriculum so that it can be there as a sustainable impact and building the future generation with the capacity. So I think these are some of the examples which can, I think, highlighted the need for the community-based interventions, which is important for the cultural and the contextual relevant information. Thank you. Over to you.
Thank you. Thank you for elaborating that and giving clarity to the method of making it sustainable in the long run. Dr. Venkatachalapathy, Dr. Ganeshkumar brought out the point of all the activities that they are doing at ICMR. And as we have said repeatedly, the quality of data, the dissemination of information, as well as to curtail misinformation, it's extremely important to have those channels of communication in a culturally sensitive, contextual manner. What do you think the IMA can do to ensure that this happens and facilitate this on a long term basis? Over to you, sir.
Yeah. Uh, Definitely, IMA has got a very, very important role to play. IMA has got around nearly 1,800 local branches all over India. It has got a footprint right across from Kashmir to Kanyakumari, north to south, and from Gujarat to Assam in the east. So you go anywhere, you can find a branch and a IMA member there. So dissemination of a, not only it's the dissemination of a authentic scientific data is very, very important, and this IMA is being doing all these days, and it is even doing today also, and it has done in the past, and particularly in the face of COVID pandemic. IMA played a very, very important role in spite of we losing nearly 2,000 doctors for COVID. So it's a very, very high figure that we lost. In spite of it, IMA is working very hard hand in hand with the government. Having said that, and I'm particularly personally, in fact, I am a pediatrician and a clinician running my own hospital, and my hospital was made as a COVID hospital. I knew how much difficult it is to convince the patients either giving a vaccine or not giving remdesivir. See, the decision has to be left to the clinician. In fact, patients and the public, they used to come once the COVID positive, they were under the impression that they should get remdesivir. So they used to bring lot of pressure. Many politicians used to call up, many senior doctors used to call up, sir, we are sending this patient, please start remdesivir. So we took a lot of time. So first of all, IMA had to educate its own members. That is the time when these webinars came into picture, and lot of webinars were conducted by IMA, and proper scientific and professional data was disseminated, and thoroughly it was well educated, so that we can use that whatever the remdesivir to a appropriate patient, not for all. Just because you come COVID positive, they don't require remdesivir for that matter. So that is one thing. And second thing, later part, when the vaccine was introduced, we had a lot of resistance. So there was a lot of misinformation campaign or anti-vaccine lobby that was working due to lack of information. So that also was to be withered off by instructions from the headquarters IMA, that we ourselves should take vaccines and shoot a video and post it on social media. So since social media is a double-edged sword, so in social media we used to see a lot of misinformations also. To countering all those misinformations was really a humongous task, and IMA played a very important role in countering all those things. And today I think we did we did a very wonderful job. We were partner to the government in saving many lives. And having said that, in fact, one more point which always IMA is asking the government, every budgetary presentation we give a health manifesto. And I have no hesitation in sharing this information, that our Indian health budget is very, very low when compared to our own neighbors like Thailand or Malaysia. We are somewhere around 2% of the GDP, whereas these small nations are having somewhere around 5% of their GDP. So that itself is a huge, huge lacuna. So GDP allotment, you have to increase the health budgetary allocations. I think that would also help in a long way to take care of our public health. So, having said that, I would conclude my talk regarding this question. Thank you.
Thank you so much. Yes, indeed. From CII, we are always, every year, it's the same story: increase the budget allocation, and the needle moves, and then you hear it is not sufficient again and again and again. So, in the interest of time, I believe we are 4 minutes over time. I would request Dr. Sanjib Bandyopadhyay to come in and help me and assist me in closing the context. So many points have been brought up, Doc. What would you say are the 2 or 3 most critical takeaways from the conversation that we've had so far?
Number one is different professional organizations with their expertise should be given due space, due recognition, and due respect in formulating policies. Second point is the lessons learned from this pandemic should be taken into account. My last and third point, the experience of the field workers, those who are from the grassroots level, their experiences should be taken into account while formulating policies and combating this infodemic problem. Over to you, ma'am.
Thank you so much, the esteemed panelists, for your very, very valuable and practical approach to addressing this. And I really sincerely thank the Voice of Healthcare on this auspicious occasion for giving us all an opportunity
Just
to
a
get
last point. Can I make?
and
Can I come in?
yes, please come in, Ravinder. Come in.
Yeah. Only thing is, I appeal through your platform that see, IMA is a very important stakeholder in health matters. So whenever a health policy is made, I urge the government to take IMA as a party before they just bring out a policy and then go back on it. That should be their way forward.
Absolutely. In a democracy, everybody's voice should be heard. So back to you, Ravinder.
So, thank you, ma'am. And as we reach to the end of this insightful session, we would like to extend our gratitude to our esteemed speakers for sharing their valuable expertise and perspective. Your contribution has provided with a deeper understanding of the challenges and opportunities in preparing for the future health crisis. A special thank you to our session moderator, Dr. Shubnum Singh, for guiding this discussion thoughtfully. Thank you once again for all of your time and sharing the knowledge, and we look forward to your participation in our future initiatives. Thank you.
Thank you. Thank you so much.
Thank you.
Namaskar.